So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good afternoon and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. And it is with great pride that Clarinet serves as a digital partner for this online event called Neonatal Pathshala series, hosted by the National Neonatology Forum Gujarat chapter. And the focus of today's session is clinical assessment of shock. Now, without wasting any further minute, let's begin today's session with the spirit of the forthcoming 78th Indian Independence Day 2024. And for this, I would like to invite Dr. Kunal Ahiya, sir, the Honorable Secretary of NNF Gujarat chapter, to start the event today with his enlightening words and for the further coordination. So the rise is all yours, sir. Please proceed.
Thank you so much, Ritu. So today we are focus series, and today we are lucky to have Dr. Gurdev Chaudhary with us. So he will be talking about the clinical assessment. A very important point is we should also see for the clinical points also. So welcome, Dr. Gurdev. Before starting the session, I would request Shwetal ma'am to say a few words. Ma'am is the president of Gujarat State NNF chapter.
Thank you so much, Dr. Kunal. I would not like to be with the session, and welcome, Dr. Gurudev, for sharing your expertise around a very critical topic of shock. And really, Gujarat NNF is privileged to have this focus series every second Wednesday constantly. The perseverance is really great. Welcome, sir. I would like to ask Nitin to share the CV of the sir. Introduce
Good afternoon, everybody. Good afternoon, everybody. I welcome you all. Before we begin the scientific session, let me introduce our faculty today. The faculty today is Dr. Gurudev Chaudhary. Many from North India would be probably aware about him. He is a DM Neonatology from PGI Chandigarh in the year 2001-2004. Dr. Chaudhary has received NNF Gold Medal Award in 2003 at NNF Annual Convention held at Hyderabad. He has many national and international publications to his credit, including a chapter in the South Asian edition of Guwahati. Currently, Dr. Gurudev Chaudhary is the director at Ankur Kids Hospital at Jalandhar, which is an NNF accredited unit running successfully NNF fellowship program since 2012. And he has trained more than 20 NNF fellows under him. And his area of interest is neonatal ventilation and obviously POCUS, which we'll be discussing today. Over to you, Dr. Gurudev, for the scientific part. Thank you.
Thank you very much for the nice introduction. I'm really privileged to be part of this prestigious series of POCUS. And today I'll be talking about the clinical assessment of neonatal shock. Are the slides visible?
Yes, visible.
Yes, sir.
So, neonatal shock is a very important topic because all people who we are dealing with newborns really dread this complication, and we should know how to assess clinically these babies so that we can intervene in time and save lives. So it's a complex clinical syndrome caused by acute failure of circulatory system. It's characterized by imbalance between tissue demand and the supply of substrates. There is inadequate delivery of oxygen and nutrient substrates, and there is also inadequate removal of metabolic waste products. So thus, what happens is, due to all these problems, cellular dysfunction occurs and ultimately cell death occurs. Here I would like to draw your attention to the fact that nowhere in this definition there has been a mention of blood pressure. So I'll be repeatedly emphasizing on this fact because many of us have a misconception that shock is same as hypotension. It's not the same, especially in neonates. I will tell you how. So this is a simplified chart in which you can see the physiology of oxygen delivery to tissues. It depends on the blood oxygen saturation and the cardiac output, which in turn, cardiac output depends on heart rate and rhythm and stroke volume. And blood oxygen saturation depends on the hemoglobin level, that is oxygen carrying capacity, and the blood oxygen saturation. So the stroke volume, which is an important determinant of cardiac output, depends on the preload, which means the amount of blood which is going through the venous pathways to the right atrium and ultimately to the right ventricle and through the pulmonary veins to the left ventricle. That is a preload. And afterload is the peripheral vascular resistance of the main capillaries, pulmonary as well as systemic capillaries. And the contractility, that is the myocardial function of the heart. All these determine the stroke volume. Initially, when you increase the preload, the contractility increases due to Starling law. But if it is beyond a certain limit, then the myocardium starts failing. Then in blood oxygen saturation depends on airway, breathing, and FiO2 in which the patient is breathing. So any abnormality in any of these cogs will stop the wheel of oxygen delivery to tissues and may lead to shock. So now we come to the various reasons why this shock occurs. The very unique thing, which is unique only to perinatal period, is perinatal transitional circulatory instability. And this is the most common cause in first 72 hours, especially in preterm babies less than 28 weeks. And the reasons are multifactorial. First is immature myocardium, which is not able to respond to the sudden increase in afterload after birth, which happens due to removal of a low resistance placenta circulation after we clamp the umbilical cord. Then there is pulmonary hypertension due to respiratory distress syndrome, which is generally accompanying such low gestation babies. Then there is persistence of ductus arteriosus, which leads to left to right shunt, and there is loss of blood from the PDST occurs from the systemic circulation. And then immature neuroendocrine systems and receptors, which are not able to respond to like they would have been in a term baby or in older children or adults. So the compensatory mechanisms are also not working properly. And these reasons lead to perinatal transitional circulatory instability. But most of these cases, only there is hypotension without associated clinical or biochemical signs. So we should be aware of this condition, and we should be aware when we should treat these cases. I'll be discussing this in detail later on the slides. Another commonly suspected but not often the primary cause is hypovolemic shock. Most of us are also pediatricians, so in pediatrics, hypovolemic shock is the commonest shock, but in newborns, it's very uncommon. And generally, we already are expecting, if we know the causes, like fetal-maternal hemorrhage, if gynecologist told there was vasa previa, if during delivery there was slippage of ligature and there are bleed from the cord, then you would obviously know that it will lead to blood loss and shock. Then if there is in the extremely preterm babies is being cared for under a radiant warmer and you're not taking care of the losses, then transepidermal losses and polyuria because of immature kidney can lead to hypovolemia in these extreme preemies. Then in our country, even in newborns, because of faulty feeding practices, bottle feeding and unclean environment and hands, infective diarrhea and dehydration is also very common. I've seen many newborn babies coming with diarrhea, dehydration, renal failure, shock. So it's not a very uncommon thing in our country. And then any baby who's sick may have a massive pulmonary or CNS bleed, and that may lead to hypovolemia. So we should be knowing about these reasons, then only we can treat them. The more important and common problem in our this age group is neonatal age group is distributive shock. And it's due to maldistribution of blood volume, and there is massive injury to capillary endothelium, which leads to leakage of fluid to interstitium or the third space. So there is distribution of this volume to inappropriate space, and maldistribution occurs. So the volume doesn't reach where it is needed. That's why it's known as distributive shock. In newborns, sepsis is the predominant cause of distributive shock. And the pathophysiological events in septic shock are a result of complex interplay between microbial products and the host. Another important reason is cardiogenic shock. It is best viewed as the pump failure. Though rare, there may be many cases of cardiomyopathy at birth, heart failure, arrhythmias, or myocardial ischemia. In our country, parental asphyxia is very common. So in term babies, it is also an important cause. The cardiogenic shock can be caused by ischemic injury to the myocardium during parental asphyxia. The main problem is low cardiac output, decreased blood pressure, and poor tissue perfusion, and produces a rapid downward spiral. Commonly overlooked cause is obstructive shock. If you don't, if our mind doesn't know, our eyes don't see. Tension pneumothorax. Any baby who's on invasive or non-invasive ventilation may develop pneumothorax. If not detected in time, it can go into tension pneumothorax, which means it starts impinging upon the mediastinum and decreasing the venous return to the heart, and that's why obstructive shock occurs. Then in babies who are on central lines, umbilical lines, there may be slippage or malpositioning of the umbilical lines, and then they can go into the pericardium and pericardial tamponade can occur. Then left ventricle obstructive, outflow obstructive lesions. These are lesions which are PDA dependent systemic flow lesions. So their systemic blood flow is dependent upon the ductus arteriosus. As soon as the ductus arteriosus closes, they present in a catastrophic fashion in shock. These are coarctation of aorta, interrupted aortic arch, critical aortic stenosis, hypoplastic left heart syndrome. Then rare causes are dissociative cause, which may be due to profound anemia due to any reason, or methemoglobinemia. And because the shock doesn't know our classification, so most of the neonates present with mixed shock, especially in advanced stages. So how does this shock clinically progresses? The compensated shock. This is the initial beginning of the shock. The vital organ function is maintained by our intrinsic compensatory mechanisms such as venoconstriction, fluid shift from interstitium to intravascular space, arterial vasoconstriction. Our intrinsic compensatory mechanisms, they are kicking in. Increased secretion of angiotensin and vasopressin allows the kidneys to conserve water and salt. Release of stress hormones, catecholamines, enhances myocardial contractility. And the baby also starts decreased spontaneous activities starts, which decreases the oxygen consumption. But if we are not intervening in time at this stage, then the baby goes into uncompensated and more appropriately decompensated shock. In this, despite intense arterial constriction, increased heart rate, blood pressure, and cardiac output, they start declining. Here, the blood pressure starts coming in. So lowered perfusion pressure leads to progressive blood stagnation, anaerobic metabolism, and release of proteolytic and vasoactive substances. Platelet aggregation and release of tissue thromboplastin produces hypercoagulability and disseminated intravascular coagulation, and patient may demonstrate impairment of major organ perfusion. And if we still don't intervene, then ultimately the baby goes into irreversible shock, in where even correction of hemodynamic derangement doesn't halt the downward spiral because already cell injury and cell death has started. Prolonged hyperperfusion of brain, heart, and kidney leads to cell death, and there is progressive worsening of coma, renal failure, pulmonary edema, and onset of ARDS. So now we come to the main, after introduction, we come to the main features of the main crux of the matter today, that is clinical feature of neonatal shock. Like any condition, first we go into the history. Gestation is very important. As initial slide, I showed that in preterm babies, perinatal transient circulatory instability is common, whereas not very common in term babies. Then we go to the perinatal history, vasa previa, cord accidents, perinatal asphyxia. If there is history of chorioamnitis, then PT-PRM in the mother, preterm premature rupture of membranes. Then we can think of some septicemia, which may present with shock. The day of presentation of shock is very important because first the perinatal instability will be there in first 72 hours, whereas PDA closure, cardiac output failure will be there after 3 to 4 days when PDA closes. And then sepsis generally starts in end of first week or the second week. If there is background of sepsis, baby is in a newborn ICU or in some infected place. Then history of respiratory support, if there is present, then we have to think of cardiac tension pneumothorax and other problems related to that. Then we go to the general physical examination. Obviously, the color is most important thing we first see in any baby. Mottling of skin is there when the baby is in shock. Anemia has to be assessed if there is hypovolemic shock. Then cyanosis can be there in all shocks later in the stage, but can be early finding in this left ventricular outflow obstruction lesions. The decreased activity, temperature, core as well as peripheral temperature. There will be a difference between core and peripheral temperature. We'll be coming to these signs later on also. The signs of dehydration, if we are suspecting hypovolemic shock, anterior fontanella, skin turgor, mucosa, sunken eyes. Then we go to the vital parameters. Heart rate, general tachycardia occurs when the shock starts. Peripheral pulses, radial femoral dorsalis pedis are very important. The radiofemoral delay is important because if that is there, then we can think of some cardiac cause. The respiratory rate increases in response to metabolic acidosis. Capillary filling time is a very important clinical parameter. More than 3 seconds is quite significant. If it is more than 4 seconds, it is very specific for shock. Saturation and blood pressure. We'll be discussing the blood pressure in detail. Then on systemic examination, chest, asymmetric air entry or inflation may be there in tension pneumothorax. Then CVS radiofemoral delay will be there in left ventricular obstructive lesions. Muffled heart sound will be in pericardial tamponade and displaced heart sound in pneumothorax. Abdominal hepatomegaly may occur in cardiogenic shock and distension may be due to NEC or paratic ileus in sepsis. In CNS, we may have findings of encephalopathy, seizures, and the neurodeficits may be there if there is massive bleed with intracranial bleed with hypovolemic shock. When the shock is not properly controlled, then you can go on to signs of major organ dysfunction, like in brain, agitation, stupor, kidneys, oliguria, GIT, GI bleed, or erosive gastritis. In liver, ischemic hepatitis and hematologic may be there. Coagulation abnormalities may be there. DIC and thrombocytopenia. So the clinical signs of progression is also very important. Initially, when the patient is in compensated shock, the signs are pallor, tachycardia, tachypnea, cool peripheral skin, and increased capillary filling time. Ideally, shock should be detected at this time for better prognosis. If we delay it, then obviously the uncompensated state starts and then very difficult to stop the downward spiral. As hemostatic mechanisms are exhausted and become inadequate, the metabolic demands of the tissue increases and the uncompensated stage ensues. The signs of uncompensated shock are falling blood pressure. So blood pressure is coming when already we have lost the game. Child is already in uncompensated shock, so blood pressure is coming at that point. Very prolonged capillary filling time, tachycardia, cold skin, rapid breathing, reduced and absent or absent urine output. And in irreversible shock, you will get signs of multi-organ dysfunction. So now we come to the main conundrum of blood pressure. Blood pressure is in neonates is such a difficult problem because there are multiple definitions. At least 15 type of definitions are there of neonatal hypotension. And 3 of these are very commonly used. First is systolic or diastolic blood pressure less than 5th centile of nomogram by Jubro et al. They have published these nomograms in Philadelphia Neonatal Blood Pressure Study Group in Perinatology 1994. So I'll be showing in the next slide. Mean arterial blood pressure less than the numeric value of the gestation. This is not backed by any data, but it's expert opinion of joint working group of British Association of Perinatal Medicine. But it has stuck and it is most widely used definition. Then mean arterial blood pressure less than 30 millimeter is based on assumption that cerebral blood flow pressure is blood pressure dependent at mean arterial pressure around 30 millimeter of mercury. So these are the 3 common definitions which are being used for blood pressure in neonates. And when you have multiple definitions for one thing, it is sure that you don't know the actual definition. This is the nomograms of systolic and diastolic blood pressure by Jubro et al. Published in 1994, and these are still followed. Anything less than 5th centile is taken as hypotension, systolic as well as diastolic. Now, here we will see how these definitions fare against the systemic blood flow, because it is the systemic blood flow which matters, not the number which is displayed on your monitor. The systemic blood flow is what determines the health of the baby and the duration of the baby. So in these studies, when in the older studies before 2000, the left ventricle outflow is taken as a surrogate marker of systemic blood flow and measured by indwelling cardiac catheter. And the value of less than 150 ml per kg per minute has been taken as low systemic blood flow, or 10th percentile has been taken as less than 10th percentile has taken. And these are population studied as preterm babies. In some, the PD has been included, in some PD has been excluded. And you can see that the specificity, sensitivity, positive predictive value and negative predictive value are not so great, even at mean BP less than 30 millimeter of mercury. In the relatively newer studies, SVC flow has been noted by a functional echocardiography and again compared with mean BP less than 30 millimeter of mercury or mean BP less than gestation age. Here also you can see that there is improvement in negative predictive value, but not much sensitivity is there, and positive predictive value is quite low. So here we can see that blood pressure doesn't correlate so well with the systemic blood flow. So our CPG guideline by National Neurology Forum to 2023 has come to our rescue, and it has again given a very detailed analysis and the final recommendation how to go about knowing about whether the blood pressure is low or not. So it is dependent on day of life as well as on gestation. So presence of hypotension is defined by mean arterial pressure less than gestation and age in weeks. If gestation age is less than 32 weeks and postnatal age is more than 24 hours, or if gestation age is between 32 to 36 weeks of any postnatal age. So if the gestation age, a mean arterial pressure is less than the gestation age number in weeks, for example, if a baby is 30 weeker and baby is now 7 days old, so mean arterial pressure less than 30 will be taken as hypotension. And in babies who are less than 32 weeks and less than 24 hours of postnatal age, the mean arterial pressure less than 5 millimeter below the gestation age. So for example, a baby is again 30 weeks now and the age of life is less than 24 hours. The mean arterial pressure should be less than 25 to be labeled as hypotension. And for babies who are term or post-term, systolic or diastolic BP less than 5th centile based on nomogram of Jubro et al. Is taken as the level at which we label as hypotension. So you can see again there is so much complications in the definition of blood pressure, but at least now we have a solid recommendation which is based on whatever available literature is there. So we can use this definition for labeling hypotension in these babies. Another problem is whether to use a non-invasive blood pressure or invasive blood pressure for which is more reliable. So obviously invasive blood pressure will be more reliable, but it needs specialized skill and equipment and it's not available in non-units. And there may be catheter-related complications such as infection, bleeding, thrombocytopenia, ischemia. And even if accurately measured, again, it doesn't correlate very well with the systemic blood flow. There have been multiple studies where again, invasive blood pressure also has been shown to not be accurately correlating with systemic blood flow. Whereas NIBP has significant inter and intra-observer variability depending on the cuff size, the method used, and in ELBW babies, NIBP is generally overestimated. So both these are not foolproof. But IBP, I'll come to the next slide, when we should use NIBP and when we should use the IBP. Again, NNF CPG guidelines have come to our rescue. They have advised that non-invasive oscillometering method should be used and blood pressure cuff should be appropriate size. That has a cuff width of circumference ratio of 0.5. So this is a consensus recommendation that the cuff size should be the cuff width to arm circumference ratio of 0.5. This should be the cuff width of the blade. And depending upon the arm circumference, you have to decrease or increase the cuff width. And guideline development groups suggest that non-invasive blood pressure readings be interpreted along with the clinical and biochemical parameters of perfusion. So you don't need to only treat the blood pressure readings, you have to correlate clinical and biochemical parameters. And if there you have functional echo with you, then you should even use that to finally make a proper comprehensive picture and then go about treating these cases. We'll be coming in next slides to these things. Then there is a conditional recommendation for IBP. In newborns who have already tissue hypoperfusion or low blood pressure or being treated with vasoactive agents for shock, here in these cases, invasive blood pressure monitoring should be done through umbilical or peripheral arterial line. And it should be done in those centers in which resources and skills for invasive blood pressure monitoring are available. So you should not be putting arterial line, umbilical arterial line in all newborn babies. It's not needed. Only those babies in which already you are suspecting hypotension, already suspecting shock, and you already started inotropes, in those babies for proper monitoring and further guidance to the management to decrease or increase the inotropes, you can start invasive BP monitoring, because it needs specific skills and resources, and also it can have some complications also related to the invasion. So some people say, very commonly residents, they start dobutamine or dopamine, थोड़ा सा सर blood pressure कम लग रहा था, थोड़ा बच्चा ढीला लग रहा था, कलर अच्छा नहीं लग रहा था, तो dopamine थोड़ा start कर दिया, dobutamine कर दिया. So is there any harm? Definitely. There are perils of treatment only on the basis of BP. So studies have proven that treatment of low blood pressure in the absence of signs of end organ perfusion leads to unnecessary overuse of inotropes, which are themselves a source of adverse effects, as well as poor long-term outcomes in high-risk units. And this is another flip side to this also. Low blood pressure is not a mandatory criterion for initiating treatment for shock. Sometimes residents may say, sir, blood pressure तो ठीक था, बच्चा बिल्कुल mottled हो रहा है, CFT prolonged है. As we have seen in the previous slide, in the compensated phase, the blood pressure doesn't start falling. It falls only under decompensated. So for initial treatment of shock, you don't need to have a low blood pressure, because we want to treat the baby in the compensated phase when we can save the baby. We don't need to wait for uncompensated phase to start for the blood pressure to fall before starting treatment. So both ways, BP is not a criteria to start treatment. Even if it is decreased in isolation, we don't need to start. Even if it's not
those who are controlling ClearNet, please mute everyone. There is a lot of noise coming in. Dr. Gurdev, just keep the things in English, because many participants have joined from Bangladesh in this. So I couldn't see many people from Bangladesh. So they will not be able to understand. There are other people from other countries also have joined in. Hello?
Should I continue?
Yes, please continue.
Okay. So now we come to
from the Dr. Silva, and I think please somebody mute Dr. Silva.
perils of treatment only on the basis of BP in preterm babies, in very preterm babies, and extremely low gestation age newborns. Isolated hypotension in initial 7 days, especially within 72 hours, is very common in extremely low gestation age newborns. So there has been a very good study by Batten et al. Published in 2013. They compared 15 different definitions based on systolic BP, diastolic BP, fifth centile for more than 3 consecutive values, less than fifth centile for more than 3 consecutive values, mean arterial pressure less than 25 for 3 consecutive values, mean arterial pressure less than gestation age preterm neonates for less than 26 weeks, in less than 26 week babies, and less than postnatal age of less than 72 hours. The authors concluded that neonatal outcome did not improve with antihypotensive therapy with any of the 15 definitions, and a number alone cannot be used for initiating antihypertensive therapy, and may not be utilized as outcome were similar or worse in treated group versus the non-treated group. So if you are treating hypotension just based on the numbers, then you may be doing more harm. So don't treat the numbers if the baby is well. I think this is a very important message which should go today in this topic. But should we treat isolated hypotension preterm? Yes, in some cases we need to treat. In very preterm babies born at less than 32 weeks of gestation, in first 24 hours of life, isolated hypotension without any clinical or biochemical poor perfusion signs may not be treated unless it persists. And mean arterial blood pressure cutoff to define hypotension may be centile based. Severe isolated hypotension may be defined as median mean arterial blood pressure less than 5 millimeter below the gestation age. As I previously said, if the gestation is 28 weeks, if it is the BP is less than 23, mean BP is less than 23, then you need to treat if it is persisting more than 15 minutes. From 24 to 72 hours, hypotension without any clinical and biochemical perfusion may be treated, and the blood pressure cutoff level will be same as the gestation age of the baby. After 72 hours of life, there is insufficient evidence to recommend for or against treatment of isolated hypotension. So isolated hypotension needs to be treated in some situations if it is very low, that is even less than 5 millimeter of mercury below the gestation age of the baby, or if it is persisting for a long time, then you should be treating. Otherwise, if it is a single number and otherwise the baby is clinically well, biochemically normal, then you don't need to treat such babies. Now we have seen about the blood pressure. Is there any predictive value of other clinical hemodynamic variables? So these are the hemodynamic variables which we see to clinically diagnose shock. First is capillary refill time, more than 3 seconds, then more than 4 seconds, then blood lactate concentration, then central to peripheral temperature difference, more than 2 degrees Celsius, and then combination of clinical variables like mean BP and capillary refill time and lactate. So if you are, you can see here that best negative predictive value is of capillary refilling time, and specificity as well as negative predictive value is of capillary refilling time, and sensitivity is very good for blood lactate concentration. Other just signs are not very good at correlating with actual low systemic blood flow. In all these studies, superior vena cava flow was seen by the flow this functional echocardiography, and it was compared with these signs, and specificity, sensitivity, positive predictive value, and negative predictive value of these were calculated. It was found that only capillary refilling time has a better predictive value as compared to the other signs. If it is also added to the other signs like lactate, and here they have not studied other combinations, then definitely you can improve the predictive value. So what should be the threshold to treat? Threshold to treat should be the presence of hypotension as defined earlier, and the presence of at least one of the following clinical or biochemical abnormalities suggestive of poor perfusion. Capillary filling time more than 3 seconds, urine output less than 1 ml per kg per hour, lactate level more than 3 millimole per liter, base deficit more than 8 millimole per liter, and in term units, core peripheral body temperature difference between above 3 degrees Celsius. So these are the clinical signs, and this is I forgot to mention here, this is on the basis of again the clinical practice guidelines of NNF. So these are the signs, physical signs along with blood pressure, which give us the threshold to treat. However, the blood pressure is not a mandatory criterion for initiating treatment for shock, as blood pressure may be maintained in the compensated phase of shock. So it's very important that we take home this message that don't treat the numbers. We have to look at the whole clinical scenario, and then only we can jump to the conclusion of treatment. So in the end, I would like to conclude with following things. Neonatal shock is a catastrophic event. Early accurate recognition of shock, identification of etiology, and aggressive management is the key to intact survival. Over-treatment on the basis of just numbers, that BP is also detrimental and can have lasting sequelae. A comprehensive approach should be taken on the basis of entire clinical background, physical signs including BP, and biochemical parameters like lactate and metabolic acidosis. The clinical assessment is not foolproof. We have seen various studies, even in the most experienced hands. Here comes the role of functional echo, which can effectively fill the gaps in entire clinical biochemical scenario. And newer modalities like near-infrared spectroscopy and electrocardiometry also warrant attention. Thank you very much.
Hello, good afternoon, doctors. Good day. How are you?
Fine, sir.
Okay, so sorry, Kunal.
Yes, sir.
So there are questions if you want to ask. Some people are asking, and but this is something is very unique and there are many people who have joined from Bangladesh, from UAE, from Arabic countries. So there are many participants from there. So we all welcome them. It's real enthusiastic, and they want to, like, the shock is something everybody wants to know. And there are questions. Kunal, if you want to, can you
Yes,
see the
sir.
question in the chat box? Yes, please.
Yes, sir. Yes. So they want Dr. Manan Abdul wants to know about the warm and the cold shock.
Yeah, Dr. Manan, he is the head of department and he is a professor of neonatology at Dhaka. Welcome, sir. Good afternoon.
Thank you, Dr. Mohit sir, and also speaker Dr. Choudhury, and also organizer. Thank you very much for giving us the opportunity to learn this kind of Zoom session. Thank you very much. Thank you again.
So these warm and cold shock are the terms used for generally for septic shock. Initially, when during the compensated phase, there is peripheral vasodilatation and there may be some bounding pulses also. And at this stage, the periphery may actually be warm because it's distributive shock. There is peripheral vasodilatation under the influence of lipopolysaccharides and inflammatory mediators. And then ultimately, when the cardiac output also starts falling, then there is peripheral vasoconstriction, and that is uncompensated phase, and that is known as cold shock. So these are the terms more commonly used in pediatric age group as compared to newborns, but these are the terms used for septic shock.
So next question is what are the early echo findings in shock?
So I would refer this to Dr. Mohit Sani because I'm talking about the clinical part only.
Yeah. So there will be sessions on echo finding of the shock. So we started with the clinical assessment. So after the clinical assessment, we'll go to the echo and everything. And as Dr. Gurudev also mentioned regarding the Mayer's and non-invasive methods of assessing the shock, we will have sessions on that also. So there will be a whole series on shock in this. So we will be doing that step by step. We will approach and do that.
Next question is there a hypertensive shock also?
Hypertensive, you can say normotensive if this patient is an early compensated shock, then it can be told as normotensive, but I don't know about any hypertensive shock as such.
Yeah. Can I come in?
Yeah.
So the hypertensive shock basically is when in compensation, when the body overreacts and it causes the excessive constriction of the vessels. So your blood pressures will be higher than the normal limit. So it's a kind of increase afterload. So because of increase afterload, your cardiac output will go down and your tissues will be in shock because of the poor perfusion. Your cardiac output goes down because of high afterload. So that is what is the hypertensive shock. Yes. So that is rare, but that is an overcompensation by the body.
Then next, please discuss on the choice of ionotropes in shock.
We will have that session also. This particularly, I requested Dr. Gurudev to restrict to the clinical assessment because we start with the clinical assessment. Then on vitals, when we will go, we will discuss vital sessions, and then there will be echo sessions, and then there will be treatment sessions. So there are a whole lot of series will be there on the shock.
Next is management algorithm of distributive shock in preterm low birth weight newborns.
Sir, Dr. Gurudev, if you want to touch around, you can please, you are free to do that. I know we just restricted this session to clinical assessment, but
Yeah.
please.
Like the algorithm, it will be difficult for me to tell orally, but definitely first we have to start with the bolus, normal saline bolus, and then ultimately gradually we'll shifting to the inotropes and other things.
Okay. So next is in hypertension, pulse pressure can be used for treatment.
Sorry, Kunal?
Yes, sir.
Yeah, what was the question? Sorry, I was.
In hypertension, can pulse pressure be used for treatment?
So, Dr. Gurudev is there?
Yes, sir.
Yeah. Hypertension, pulse pressure can be used for treatment. I didn't get the question actually.
Dr.
can answer
Mahendra,
if you
you
want.
can switch on your video and you can ask directly also if you want. Dr. Mahendra Gupta, you can ask the question directly also.
Okay.
I think so. He must be trying. He's trying to ask what I am getting. I don't know. I may be wrong. That with hypertension, what will happen? In high output shock or in PDAs, there is a wide pulse pressure. Then, because of dilatation and constriction, sometimes what happens? The wide pulse pressure can vary. It sometimes decreases depending on if you are using any inotrope or not and all that. But that is very variable with various vessels in various parts that are supplying. Like in brain, the reaction of the vessels will be different from the vessels in the body. So that's why just by using the pulse pressure, we should not be treating the shock, because in that way what we are doing is we are trying to treat only either the mean blood pressure or one part of the blood pressure. And nowadays we always say that the blood pressure you have to see in three components: systolic blood pressure, diastolic blood pressure, and mean blood pressure is a product of all these two. So we should not be treating it just on the basis of pulse pressure, whether it is narrow or wide. I think so. This may be his question, but still.
Probably he asked for hypertension, not hypo.
Yeah. So in hypertension, again, what will be the issue is systolic component is high or diastolic component is high. That because the reasons for that will differ and the drugs will differ. So that's why just by seeing the pulse pressure in the blood pressure, if we treat hypertension, then again it becomes tricky. But this is what I am getting. I don't know. I may be wrong. If still wants to clarify, you can please write in the chat box or you can unmute and ask.
Can I ask the next question? So one more question is there. Is there any role of organ-specific biomarkers in shock?
Organ-specific biomarkers can be used for for renal compromise, for liver function test. Definitely, it has a role, but generally, once the organ starts getting impacted, then the battle is already lost by us, because the cellular dysfunction and death has already started setting in. So only then organ markers will be coming into the blood, like in cardiac, there may be NT-proBNP, like in DROP-I, liver SGOT-PT may be raised. and in the kidneys also you can have microproteinuria and all those things. But these actually are markers of late stage of shock, and we should try to treat shock early in the phase when the compensated phase is there.
I think that's all from the questions in the chat box. If anybody want to ask any question directly, they can unmute themselves, and I will wait for a minute or so if anybody wants to ask any question. I think there are no more questions. So, Dr. Nitin Agrawal, do you want to wind up? Dr. Nitin? I think he's lost the connection. So thank you so much, Dr. Gurdev. It was a wonderful session, and we have come to know about very many things about the shock. And it is very important that we first clinically judge whether the baby is getting into shock or not, and as well as you emphasize the importance of that the blood pressure itself is not the sole definition for defining shock. So there are clinical parameters are there, and there are various stages of shock also. So thank you so much for elaborating them in detail. Thank you so much, Mohit Sani sir, for continuing with this focus series. We have reached series number 16. And I hope that you allow us to continue with this series, and we can will be more than happy that our audience, and I especially thank all the people from Bangladesh also who have spared that time to join us, and as well as the audience from India as well, Gujarat as well. So thank you, sir. Mohit sir, would you like to say something?
Thank you very much. Yes, we will, I will be more of encouraged to continue with this. It is a good platform. Like once a month, we will continue. Then what we'll do in the end, from 1 till end, the whole series, we can make one document with their links, and then we can share in the groups, so that they will be able to see the whole focus series all together on our YouTube channel. So that will be a good thing. And really thankful to Dr. Gurdev Chaudhary, who agreed to, and he is a very senior and very renowned neonatologist of India. So thank you very much to be a part with our series. And thank you, Kunal and Gujarat NNF, for making it possible every month. Thank you very much.
Thank you so much, Mohit sir. So thank you, everyone. Thank you so much. Sorry, Shwetal ma'am is unable to join, stay there till the last. But she has conveyed her regards. Thank you, everyone. Like to thank Dr. Gurdev for this wonderful session. Thank you, Mohit sir, for the allowing Gujarat NNF to continue with the series. Thank you all the EB members and our advisors, Uma ma'am. Welcome, Uma ma'am. So
Thank you very much.
Thank you, madam.
Thanks, Dr. Mohit. Thanks, Dr. Kunal. Thank you very much.
And thank you all the delegates. Thank you, ClearNet, for the seamless experience. Thank you all. Ritu, we can conclude the session.
Thank you so much, sir, for your wonderful and insightful words. So with all your permission, we are signing off for today and hoping to meet you again in another interactive session in the near future. Till then, stay safe and healthy and have a nice day. And wish you all a very advanced Happy Independence Day. Thank you very much.